Hi everyone. So if you're watching this video, either you've been diagnosed with larynx cancer or someone you know has been diagnosed with larynx cancer and you've talked to your doctor about different treatment methods or he's recommended a treatment method and you just want some more information. So in this video, I'm going to go over some very basic anatomy and then go over the different types of larynx cancer, the stages, and then talk about the different treatments and why one would be a little bit, what are the advantages and disadvantages of each treatment modality. Okay, so this is a quick 3D rendering of the head, and the larynx is this area right here, and some people call it the Adam's apple or the voice box, and some people call it throat. So you might hear people call it throat cancer, but throat is very wide. It could be anywhere in this entire area, could be throat. And so what we're talking about today is glottic cancer. And glottic cancer is basically this area in the voice box, which is the vocal cords. The vocal cords are right here. And then above the vocal cords is this little flapper that's called the epiglottis. Is the thing that like flaps down and covers the larynx when you're swallowing. And then there's this area called the supraglottis, which is right above the vocal cords. And there's this area called the subglottis, which is below the vocal cords and connects the vocal cords to the windpipe or the trachea, okay? Um, there's a great video here of someone doing a laryngeal exam, and this is basically looking down um, from the top down at a vocal at a voice box. And so this white thing is the vocal cords. It's the right side and the left side. This area in the front is called the anterior commissure. This thing right here is the epiglottis. These things are called the arytenoids. So what we're talking about is cancers of this vocal cord. And down here you can see the subglottis. So the vocal cord moves back and forth. Like when you want to breathe, it opens. And then when you talk, it closes like this. And it vibrates. And later on this video, they're going to do what's called stroboscopy, which lets you see the... she's doing a pitch. So you can see the vocal cords tightening as she changes pitch, and here's the subglottis. Now they're going to do stroboscopy, and you can see the wave pattern in the, yeah, there's the wave pattern in your vocal cords. And so we're talking about cancers of this area. Mostly these are caused by smoking. It's almost like 95% in smokers or higher. And so the different stages of glottic cancer is it goes from, it's called T staging, and it goes from T1 to T4. T1 means it's just in the vocal cords. It's just in this white area. T2 means that it's gone slightly up into this pink area or slightly down lower into the pink area below it. And so it's up into the supraglottis or the subglottis, or the vocal cord doesn't move quite right. See, you know how it opens and closes? You notice how it opens and closes? You'll see it here. See, it's closed here and then opens. It doesn't open and close quite well in T2. And then T3 means that there's so much tumor here that the side does not move at all. It's stuck. And then T4 means that it's gotten so big that it goes through this cartilage. So on here, there's a cartilage here, and it's busted through this cartilage. So T4 means that the cancer's gotten so big that it's eroded through this cartilage and is outside the voice box. Okay, so now that we know the staging that we're talking about, so T1, T2, T1 is just in the vocal cords. T2 is in the vocal cords plus a little bit of this area outside the vocal cords. T3 means it's so big it's not moving at all. And T4 means it's so big that it's gone through this cartilage. All right, so this is a great paper that I found out of Switzerland where they talk about the various treatment modalities. And so this is for early stage T1 and T2. Basically, the take-home point in T1 and T2 is that in terms of controlling the cancer, there's two ways of treating it. One is laser surgery, where you shoot a laser down from the top here and cut out the cancer with laser. And the other is radiation therapy, which is where you go every day, like 5 days a week for 6 weeks, and they give a little bit of radiation. They focus it right down on the cancer in the vocal cord. So the thing to know is both laser surgery and radiation therapy have good survival rates, so they treat the cancer quite well in this low stage. The the voice will be better with radiation therapy. So your voice is slightly better with radiation therapy, but larynx preservation overall is higher with laser surgery. So survival is the same. So treatment of the cancer is the same between the two in early stage. The voice is slightly better with radiation therapy, but larynx preservation is better with laser surgery. And the reason is that if the patient fails laser surgery and the cancer comes back, they can always drop back to radiation therapy and try to fix it with radiation therapy. However, if you do radiation therapy first and it fails radiation therapy, generally the next step is a total laryngectomy where you remove the entire larynx. Because you can't back up radiation therapy with laser surgery generally. Okay, so take-home point in early stage cancer is better oncologic outcomes or treatment of the cancer is the same between radiation therapy and laser surgery. Radiation therapy has slightly better voice, and laser surgery has slightly better larynx preservation. So you're less likely to need a total laryngectomy at some point if you do laser surgery. So in my practice, I generally recommend laser surgery if it looks like it's something that we can remove via laser surgery. They talk about this area called the anterior commissure, and that is this area in the front here. If you have a tumor here, it's very hard to get out with laser surgery, and you have very bad voice outcomes. Generally, in that case, I'll recommend radiation therapy as a first-line treatment. There is a thing called supracricoid laryngectomy, which is another open surgery that can be done for involvement of the anterior commissure. But that's a pretty involved surgery, so I usually would recommend radiation therapy as a first-line treatment for anterior commissure involvement. Okay, so really the other thing is when you get down to high stage cancer, there's T3 and T4. For T4, you should get total laryngectomy. It has better survival, better treatment of the cancer, and even if you were to get the cancer treated with radiation therapy, you generally end up with not a very functional larynx. And the larynx has two functions. Most people think of the voice function, which is important, being able to talk, but the other important function of the larynx is as a gatekeeper. It basically, what it does is when it decides what's coming down the pipe, and if it's air, it opens up and lets it into the lungs. And if it's food, it closes up and lets it down into the stomach. So it's a gatekeeper. So at T4, generally the larynx is not working well. And if after you radiate it and give it chemotherapy, it works usually less well. And you end up aspirating, which means food goes down the wrong way into your lungs, and your voice is terrible. So generally for T4, total laryngectomy is the way to go. Now T3 is where it's kind of a little bit iffy on what you should do. That's you could go either multiple ways with a T3 lesion. The oncologic outcome or the success in treating the cancer is slightly better with surgery. So if you do surgery, you're going to have slightly better treatment of the T3. But you will lose your larynx. You will need a total laryngectomy. So if you want to risk it, slightly worse treatment, and you want to save your larynx, you could go for chemotherapy and radiation. If you do chemotherapy and radiation, the likelihood that you're going to eventually lose your larynx is about 50-50 within 2 years. So half the people that undergo chemotherapy are going to be able to save their larynx, and half of them are going to recur and going to need a total laryngectomy. One way of deciding which way to go is to do what's called induction chemotherapy, and they give you one round of chemotherapy. If the cancer responds very well to the chemotherapy, it's likely to respond very well to the radiation therapy, and you could go to the radiation therapy arm if you're kind of can't decide which way to go. Because the radiation therapy is more likely to work if the induction therapy works. If the induction therapy doesn't work, then you should go to surgery, because usually cancers that don't respond to chemotherapy don't respond to radiation therapy very well, but all cancers respond to surgery. Once you take it out, they're gone, as long as you get clear margins. Okay, so I hope that was helpful. So early stage cancers, to recap, early stage cancers you can treat with laser or with radiation. Radiation gives better voice. Laser gives better laryngeal preservations. With T4 lesions, you should get total laryngectomy. You should get surgery. With T3 lesions, you can kind of go either way. If your concern is more about treating the cancer, then surgery is better, slightly better, not a huge difference. If you want to preserve your voice box, then of course radiation therapy and chemotherapy is the way to go. But if you go that way, about half of you lose your larynx eventually because the cancer recurs. One way to try to decide if you don't have a strong preference one way or the other is to do a round of induction chemotherapy. And if you respond to the induction, get radiation. If you don't respond, get surgery. All right. I hope that was helpful for someone, and thanks for watching.